Hello, everyone. I hope you had a very good study week. In this class, I want to talk about the common upper limb injuries in workplaces. And it's a requirement for the other classes that you will have in this course. In the next 2, 3 classes, we will talk about the prevention mechanisms and different methods of evaluation the risk of upper limb injuries. So in this class, I mostly talk about the different injuries that may happen to shoulder, elbow, wrist, fingers in workplaces. Before I start speaking about the injuries, I wanted to give you the answer of the first question in your last quiz. So fortunately, most of you could answer correctly. So if you look at the equation that I used and how I put the values in the equation, you can understand easily that how you could evaluate and you could measure the metabolic expenditure of lifting for this worker. The other issue is that don't mix up the workplace design with job design. When we say workplace design, we mean about the table, about the chair, about how they can reach to the tools that they need, or the position of their hand when using the tool or something like that. Job design is different. If it's that job design is mostly about how many tasks they should do during a job in a shift, or how we can arrange the rotation of the shift or the break times. These things are related to the job design. So some of you, I thought that mixed up these two concepts. So, okay, let's start our class. There are some reading materials that you can use for this class, and if you want, you can look at them. So, neck and shoulder and elbow and hand and wrist problems are very common in workplaces, and it's mostly related to the type of work that the people are doing. The same that we talked before about their posture, their repetition, and the force that they are applying. So during this class, I will talk about different type of disorders and diseases that people may have in their upper limb that is related to the tasks that they are doing. This graph is not new to you. You know that when we have high demand, high force demand, and with low rep, we are predisposed to acute injuries. But when the force or the demand is not so high, is moderate or small, but the number of repetition is increasing, so the patient, the worker may be at increased risk of a cumulative type of injuries or overuse injuries. Let's review the common types of overuse injuries. One of the common chronic problems is myalgia. Myalgia means muscle pain, and there are different causes for muscle pain. It can be because of an awkward posture and muscle spasm. It can be because of repetitive tasks and muscle fatigue. It can be again because of an awkward posture. We may have an increase in the muscle tension, and so the blood supply to the muscle may be compromised, and there may be trigger points. There are different theories why repetitive tasks may cause muscle fatigue or muscle strain. One of them is Cinderella hypothesis, and it comes from the famous character Cinderella, who used to be the first to rise and the last to go to bed. The same happens to the muscles, to some fibers in the muscles when a person is doing repetitive tasks. When a person is doing a repetitive task, you start doing a repetitive task, certain fibers, low threshold fibers, will start to activate or to be recruited. Because the amount of force is very small, the low threshold fibers were recruited first. But they are the last one who will be deactivated as well. So when a person is doing a repetitive tasks and the time between two repetitions is very short, actually those low threshold fibers or motor units never go to the resting period, and they are active all the time over a repetitive task. And that is why that we have a cumulative type of loading of those fibers, and then muscle fatigue and spasm or cramps will ensue. Myofascial pain syndrome or trigger points usually happens in people that they are doing a static type of work for a long period of time. So suppose that they have a special, they should keep a posture for a long period of time, and so the contraction of the muscles or even stretching of the muscles that can cause that special tightened bands develop inside the muscle, or contraction knots inside the muscle. These knots are very hypersensitive, so when the clinician touch these knots, the pain will be provoked, and the person may have the pain in the site of the touch, or even the referral pain, the pain that is going radiating to the other part of the body from that site. Trigger points are usually in one quadrant of the body, and the common places for trigger points are shoulder, neck, and back areas. You should consider that neck pain can be associated with the different mood conditions. For example, people with higher rate of depression or anxiety, or in psychosocial environment that increase the anxiety or the stress on people, they are at a higher risk of developing neck pain. And this study is one of the examples of different studies that you can find in the literature regarding this issue. The other common overuse injuries are tendon injuries. Tendon injuries can be inflammatory or non-inflammatory, and most of them are because of cumulative type of trauma. So I want that you differentiate these two terminology. One is tendinitis or tendonitis, which means itis at the end of any word means inflammation. So when we say tendinitis or tendonitis, it means that the inflammation exists in the tendon fiber or tendon bundles or the fiber bundles. So this is an inflammation which may cause by a tear, a straining, or sometimes acute injury of the tendon fibers. Tendinosis is different from tendinitis because there is not actually an inflammation. So that is why that for tendinosis, if we give anti-inflammatory or anti-inflammation to the patient, it may not help them. In tendinosis, actually the problem is that we have micro tear or small tear inside the tendon fibers, and because of the accumulative type of injury, these fibers didn't have enough time to be healed or didn't have enough time of healing. So we have the distortion of the fibers, the compromise of the tendon function, and we have tendinosis. Sometimes we cannot differentiate tendinosis from between tendinosis and tendinitis. So sometimes it's really difficult to understand which one is the cause of the pain for the patient. So clinical approach, usually we use the term of tendinopathy when we cannot exactly say whether it's a tendinosis or tendinitis. So in general, we call it it's a tendinopathy. You should notice that in tendinosis or tendinopathies or tendinitis, the problem is inside the tendon. The tendon fibers are involved, but it's possible that we have the inflammation of the sheets that surround the tendons, and we call that tenosynovitis, because this synovial type of the sheets, they help the tendons to glide smoothly without friction, and so they can produce a liquid that somehow smoothen the area for tendon movement. I will give you some example of tenosynovitis, but I just want that you learn this different terminology and understand the differences between different terminologies. One of the other common overuse injuries is bursitis. And as I told you before, when itis is at the end of any word, it means inflammation. So bursitis means inflammation of the bursa. And bursa is a small sac filled with fluid that serves to limit the friction between a tendon or muscles and bone or two tendons. So they are actually cushioning between tendons and bones, or tendons and tendons, or muscles and bones. So when we have repetitive movement, such as when you are doing a repetitive overhead activities, you may have the inflammation of subacromial bursa. Or when we have a constant pressure on a bursa, such as when a person is leaning on the elbow, flex elbow, the bursa of the olecranon area will be inflamed. The other injuries is neuropathy or nerve entrapment. You know, we have a central nervous system which consists of brain and spinal cord, and we have peripheral neural system which consists of all the nerves that are coming outside from the brain or our spinal cord and innervate the muscles and different organs in the body. So peripheral neuropathy can happen because of a traumatic injury to the nerve or because of nerve entrapment. Nerve entrapment mostly happens when we are doing a repetitive task, and so we have the friction of the nerve over a bone, or we have the friction of the nerve over a tendon or fascia, so an inflammation of the tendon sheath. So we have somehow entrapment or impingement of the tendon in a tiny little areas that the nerve passes. We may have also neuropathy secondary to metabolic diseases. The most common one is the diabetic neuropathy, and you know that the people who have diabetes for a long period of time, they may have some problem in the sensation of their limbs, especially in the lower limb, the sensation of the toes, and so that is why the risk of injury and risk of infection is very high in these people. So they actually develop neuropathy in the peripheral nervous system in their limbs, mostly in the limbs. Neuropathic pain usually is a bizarre type of pain, abnormal sensation. We call it dysesthesia, or they have even non-painful with non-painful stimuli, they may develop pain. We call it allodynia. And the pain is usually such as shooting, stabbing, electric shock, tingling, numbness, pins and needles. These type of pains are actually very characteristics of the type of neuropathic or neural pain. Let's review some common overuse injuries in workplaces. Some classic tasks that can cause shoulder pain and injuries are working with arm above the shoulder level with extended arm, or working with arm outside the body area, raised shoulder, repetitive work, forward flexion, static work with the loads, or prolonged work with low static loads, but the duration is a little bit long. You should consider the anatomy of the shoulder. So I'm sure that you know about the subacromial space. It's a space beneath the acromion, between the head of the humerus and the coracoacromial ligament and the acromion. So different structures pass through this space, including the subacromial or exist in that space, such as subacromial bursa, rotator cuff tendon or supraspinatus tendon, the caps, the superior part of the joint, glenohumeral joint capsule, or the long head of the biceps tendon. So when we elevate the arm, this space, the size of this space will reduce. And so these structures may be compressed or be under higher pressure. You know that in normal arm elevation, we usually external rotate our arm. So you can try now. When you elevate your arm, actually your upper limb will go to external rotation to somehow maximize the subacromial space. And let the structure under the subacromial space to be in a little bit more comfortable condition. Now you can imagine when a person is doing an overhead activities for a long period of time, those structures under the subacromial space or in the subacromial space will be under higher pressure and higher compression. And if a person is doing the activities that needs a lot of overhead activation with internal rotation, such as the activity that the swimmer, for example, is doing, or a person who is using wheelchair during the pushing of the wheelchair. So all these type of activities will increase the pressure inside the subacromial space, decrease the size of the space, and so the structures which are in that area may be inflamed or they have some kind of overuse injuries. This condition is called shoulder impingement syndrome. And as you notice now, shoulder impingement syndrome is not a one disease. It's actually different type of pathology that may happen because of the impingement in that area. So it can be a bursitis, an inflammation of the subacromial bursa, which is very painful. The patient has a lot of pain and in that area because it's inflammation. We may have supraspinatus tendinitis, which is the inflammation of the tendon, or tendinosis because of the repetitive small tearing of the tendon, and so the deformation of the tendon in that area. The same is true for the biceps tendon or other rotator cuff tendon, which are passing through that space. We may also have a rotator cuff tear, partial tear, or complete tear. And so all of these conditions are related to shoulder impingement syndrome. We may have a combination of 2 or 3 of these pathologies with shoulder impingement syndrome. So it's very important that you understand that when we say that this person has shoulder impingement syndrome, it's not a one type of pathology. It can be a range of pathologies because of the compression of the structures in that area. Why some workers develop shoulder impingement syndrome while the others with the same type of task don't? There are different reasons. It can be genetic. Some people are genetically predisposed to rotator cuff injuries. It can be anatomy. Some people have a special acromion anatomy. If you look at the picture in the right side, you can see different types of acromion, and people with type 3 acromion, they usually have smaller subacromial space and they may develop impingement syndrome. But most commonly it may be muscle strength imbalance and fatigue. So when we have fatigue in rotator cuff muscles, they cannot do their job properly. Their job is to somehow stabilize humeral head in the glenoid during different movement, because you know the size of the humerus head is much bigger than the size of glenoid. So we need dynamic stabilization for when the shoulder is doing different movement. And this dynamic stabilization is mostly the role of rotator cuff muscles. So when we have weak rotator cuff muscles, or when we have a rotator cuff tear, the humeral head cannot place properly in the glenoid fossa. So we have the shearing effect of the other muscles which are stronger, such as deltoid, and we have the displacement of the humeral head, superior displacement or upper displacement of the humeral head, and so the space of subacromium will be smaller in this condition. When we have the strain and inflammation of the area under the subacromial space, the patient will develop pain in the upper and lateral part of the shoulder. The pain sometimes may reach to the arm as well. And when they elevate the arm, when they want to reach something over the overhead or over the shoulder, they will have pain. Especially they have a pain arc in a certain range, they have more pain. So let's say between 60 to 120 degree of arm abduction or flexion. It's sometimes they have problem reaching back. They have weakness in the shoulder muscles, especially rotator cuff muscles, and they have pain when they lie down on that shoulder. And sometimes within the longer period of time, when we don't have enough healing process in the area, the patient may develop tendinopathy, or sometimes even the tear may happen, partial tear or complete tear of rotator cuff. The same concept is true for the other tendons. For example, it's very common in the workplaces that the worker develop elbow tendonitis. We have two types of tendonitis, or it can be tendinosis as well. But we have two types of tendinitis or tendinopathy in the elbow area. One is in the muscles that are attaching in the lateral epicondyle, which we call it tennis elbow. And the other one is the tendons of the flexors, which are attaching to the medial side, medial epicondyle, and the patient will develop the pain in the medial side. We call it golfer elbow. The tennis elbow is more common. It's the inflammation or the overuse or micro tearing or strain of the tendons that are attaching, extensor tendons that are attaching to the lateral epicondyle. Extensor muscles that are actually do the strengthening of the fingers. They do wrist extension, and also they do supination. They contribute in supination. So any task that the person needs to do, a lot of wrist extension and supination, and work with the extended fingers. Any type of this type of activity with too much force or with small force but with a large number of repetition, they may develop tennis elbow. And why the name is tennis elbow? Because it was more common in tennisors, especially because of the bad technique. When during the backhand, you know, the tennisor in the normal, in a correct technique, they should use the shoulder to do the backhand. They shouldn't move the wrist. But some tennisors, when they do the backhand, they are doing actually the wrist extension during the backhand while they are holding the heavy a racket, and they are forcefully hitting the ball. So this forceful extension, repetitive forceful extension, can cause the inflammation of the extensor tendons that are attached to the lateral epicondyle, and that is why the name is tennisor elbow. But as you can see, it's not just the tennisors who may develop tennisor's elbow. So there are tennis elbow. There are so many different tasks, especially the task that the person should do rotation of the forearm, bending of the wrist, or they need to do stressful gripping, or they need to do jerky movement, or hit the object with the hand. So different, you can imagine different tasks that the person need to do this type of wrist movement over and over. They are more predisposed to injury. Even the people who are working with the mouse for a long period of time, and they need to hold the wrist in the extended position for a long period of time, they are more predisposed to develop tennis elbow. While the pain in tennis elbow is mostly in the lateral side of the elbow, and sometimes it refers to the forearm as well, in golfer elbow, the most problem is in the medial side of the elbow. Actually, in golfer elbow, we have the inflammation of the flexors, which are attaching to the medial epicondyle, as I told you before. And why the name is golfer elbow? It's because of the bad technique of the golfers during the swing phase of working with their stick, and so the flexion, flexion of the wrist, the repetitive flexion of the wrist during that swing phase would cause the inflammation of the flexors in their insertion site. Sorry, in the origin site. So the pain again may radiate to the forearm, and you know flexors are responsible for the flexion of the wrist, also for the grip and rotating of the forearm, mostly in pronation phase, in pronation, movement. And so people who are working with, for example, screwdrivers or with hammer, or the painters, they need to do the movement of flexion of the wrist for a longer period of time, or for a repetitive type of tasks, they may develop golfer elbow. The other common injury is cubital tunnel syndrome. Cubital tunnel syndrome is because of the entrapment of the nerve, of the ulnar nerve in the cubital tunnel. The cubital tunnel is actually a 4 millimeter passageway that is just behind the behind the medial epicondyle and the medial side of the olecranon of the ulna. The nerve is passing through the two head of the flexor carpi ulnaris muscles, and you can see in the picture in the right side the aponeurosis of this muscle and how the nerve is passing beneath of that aponeurosis. So you see that how superficial the ulnar nerve in that area is, and how it's close to that bony area. So when we have a pressure on the nerve, the nerve is actually compressed against a hard surface, a bony surface, and the patient may develop the pain and the numbness and tingling, electric shock type of sensation, burning sensation in the area that innervated by the ulnar nerve, and is mostly you can see in the left side the trajectory of the ulnar nerve. So the patient has the pain in this side, and the tingling and numbness in the the small finger, the last finger, the fifth finger of the hand, and the half of the ring finger. So if you have a prolonged elbow flexion when you are doing wrist extension, so it means that you are stretching the nerve. It's such as when you are talking with a cell phone for a long period of time, you may develop this kind of neuropathy. Or when somebody is leaning on elbow for a long period of time, or in leaning the elbow on workbench, they may again develop this type of problem. One of the most common injuries in workplaces is carpal tunnel syndrome. I'm sure that you've heard about this syndrome, and let me to talk about it a little bit more deliberately. This is the anatomy of hand, and you can see the hand has a sophisticated bony structure. So we have two rows of bone, one radiocarpal, and the other one is mid-carpal joint. So why we have two rows of the joints? Because it permits larger range of motion with less risk of entrapment or pinch, and also better protection against the force, because the joint is flatter. There is also a very sophisticated ligamentous system that hold this bones together, and also give the flexibility of the different type of joint, wrist joint movement. As you can see, the arrangement of the bones is in a way that we have an arc, a carpal arc, and this arc is shaped by the carpal bones and their arrangement relative to each other, and also the transverse carpal ligament, or TCL, or flexor retinaculum, that somehow maintain this arrangement and maintain this shape. So together with this carpal arc and TCL, we have the carpal tunnel. So in the carpal tunnel, the roof is actually the TCL, or transverse carpal ligament flexor retinaculum. The floor is the carpal bone, and we have about 9 tendons inside the carpal tunnel, 4 deep flexors, 4 superficial flexors digitorum, flexor pollicis longus, and also median nerve. As you can see, the hand has flexion and extension movement, 85 degrees of flexion, about 70-80 degrees of extension. And we have also radial and ulnar deviation. Each one, the radial deviation about 20 to 25 degrees, and ulnar deviation a little bit bigger, 30 to 35 degrees. This slide is from your reference book. You can see that when the hand is in a straight position, the strength of the hand is 100%. When the wrist is in 0 degree of arrangement. So when we have radial deviation or ulnar deviation, you can see that the strength of the hand will decrease. For example, in 25 degree of radial deviation, you can see that 20% of the strength of the hand will decrease. So the same is true for flexion and extension. In neutral position, you have 100% of hand strength. When you go to extension, in 45 degree of extension, you will 20% of reduction of your hand strength. And in 60 degree of flexion, you have 55% reduction of your hand strength. So the best position for the hand is a functional resting position. In functional resting position, the wrist is straight, the muscles are relaxed, the fingers are slightly curved, and the pressure in the carpal tunnel is the lowest one. So it's better that for the job, for the work design, the functional resting position is the best position for the hand if you want to design the workplace for the workers who use their upper limbs for their work. Again, the tasks that are repetitive, when the person needs to apply high forces on the wrist and hand area, pressure in a small area, incorrect grip, vibration, cold and heat, and awkward positioning of for example, ulnar deviation or radial deviation. So any or using incorrect tools. So all of them can predispose the person to wrist and hand injury. Hand injuries can be a one-time injuries, which usually caused by trauma, a crash, a cut, and which is very common, about 9%. And many of them are related to the power tool and also the other type of tools that the people are using. Most of the one-time injuries are traumatic type of injuries. But workers with the repetitive task may develop overuse type of injuries in their hand and in their wrist. For example, the workers who are working in the poultry processing plants, they are more predisposed to this type of injury. It can affect their work productivity, the quality of their work that they are doing, and also the absence time also can affect the industry. Carpal tunnel syndrome is happening when a person is doing a kind of repetitive task in extreme positions, wrist flexion, extension, or deviation. And the median nerve, if you remember, the median nerve was passing through this carpal tunnel. So the median nerve will be pinched, and the person will have the neuropathic type of pain and symptoms in the area that is innervated by median nerve, which means the first 3 fingers and the half of the fourth finger or the ring finger. And also some of in the advanced cases, the patient may have the atrophy of the thenar area or thenar wasting. Usually for diagnosis, we ask the people to do electromyography and nerve conduction velocity studies. And in this situation, when the median nerve is pinched or when the median nerve is under pressure, we may have the slow nerve conduction velocity in this nerve. To develop carpal tunnel syndrome, there should be either a mechanical compression of the nerve, for example, when the nerve is in contact with the flexor retinaculum and the friction between the nerve and the ligament may cause the irritation of the nerve, and so the inflammation and the problem, the symptoms of the patient. This situation happens when we have in different wrist position. Where in different wrist positions, the position of the nerve will change in the tunnel, or the pressure inside the tunnel will increase. So when the pressure is over 30, the conduction velocity will decrease. And for increasing the pressure, either the size of the tunnel should be reduced, or for some people they have a small size of the tunnel, or we have more content inside the tunnel. For example, when we have a swelling of a tendon, we have tenosynovitis, sometimes there is a cyst, sometimes there is a tumor or something. So all of this increasing of the materials inside the tunnel can increase the pressure. Here you can see two MRIs. In the left side, you can see the MRI of the wrist when the wrist is 20-degree extended. And you can see the tendon dispersed. I mean, the flexor tendons are dispersed, and you can see the yellow one is the median nerve. When we splint the person in 45 degrees of wrist flexion, you can see that the tendon shift to closer to the TCL or transverse carpal ligament. So in this condition, we may have more mechanical pressure and mechanical friction between the nerve and the ligament. Some researchers measure the pressure inside the carpal tunnel. And so you can see in the graph in your left side that in the neutral position, the pressure inside the carpal tunnel is small. When the wrist is going to the extension or to flexion, the pressure inside the tunnel will increase. Even you can see that by finger force, you have increase of intracarpal tunnel pressure, and this is independent to the wrist extension. So even by increasing the pressure of the fingers, you will have more pressure inside the carpal tunnel. So you can see that in wrist flexion, we mostly have mechanical pressure or contact stress, and in wrist extension, we have an increased pressure inside the carpal tunnel, and so we have all the symptoms related to the carpal tunnel, to the carpal tunnel syndrome. An interesting study has been done at McMaster University by Dr. Kerr and his colleagues, and they evaluated the effect of computer mouse design on carpal tunnel pressure. They asked the participants to use 3 types of mouse and check the intracarpal pressure in resting position when they they hold the mouse in static position, and when they were dragging the mouse in certain directions. And also for type C, they also check the intracarpal pressure when they pointing the mouse. As you can see in this graph, the red bars are related to the rest position. That you can see that the intracarpal tunnel pressure is almost 5, but when they hold the mouse in all 3 types of the mouse, you will see the increasing of the intracarpal tunnel pressure to below 30, and when they drag the mouse, the pressure will go over 30, which, as you remember, when the pressure is over 30, we have the sign and symptom. So you imagine that some person is working with the mouse all the day, and so they're doing a lot of dragging or pointing type of movement with the mouse, how they may be predisposed to carpal tunnel syndrome. So the message of this article that I have posted that article for you on your Blackboard is that although there are different designs for mouse, but what is important is the wrist posture and the carpal tunnel pressure. So how we use the mouse is more important, and we should emphasize that part. And by better workplace design, job design, enough break, educating people how to use the mouse and etc. Another common injury in workplaces is the Corbin disease. It usually happens because of a lot of hand twisting and forceful gripping. So we have two tendons in the thumb which have a common sheet. These tendons are abductor pollicis longus and extensor pollicis brevis. So this common sheet, because of this repetitive twisting movement, may be inflamed. We have a tenosynovitis then, and the area, the lateral side of the wrist or the radial side of the wrist will be inflamed and painful. And when the patient is moving the wrist or moving the thumb, the pain will be aggravated. This problem is more common in new mothers who have the frequent lifting of the babies, and in people who are working in the assembly lines or services, secretaries, and racket sport players. Do you remember that we have ulnar nerve entrapment in the elbow, which we called it cubital tunnel syndrome? We have another ulnar nerve entrapment in the wrist, which is less common than the other one. And it's because of the special location of the ulnar nerve in the Guyon canal in the wrist, and that superficial position make the ulnar nerve vulnerable to compressive injury. It's more common in worker that we use to pressure the hypothenar area of the wrist against a surface, hard surface, or they apply forceful flexion extension against a resistance, or they need to lift the objects, or even in some people who are wheelchair dependent, lifting of their body with their palmar pressure, with the pressure on the palmar side of the wrist. So these people are more predisposed to ulnar nerve entrapment. And again, like the cubital tunnel syndrome, the people will have pain in the ulnar side of the wrist with radiation to the small finger and the half of the ring finger, with numbness, tingling, and a sign and symptom of neuropathies. One of the other workplace injuries is trigger finger syndrome. So it's a kind of stenosing tenosynovitis. The sheet around the flexor tendon of the fingers may be inflamed and cause obstruction for the finger flexion and extension. So the patient cannot flex the finger smoothly, and when they want to return the finger in the normal position, it's usually with a snap that they can do this. So they have localized pain in the area and locking of the tendon in the sheet. It's more common in workers who are doing flexion extension of the fingers against a resistance, or using pistol air tool, or the people who are using the tools that have hard or sharp edges. And lastly, I want to talk about white fingers, which is musculoskeletal problems secondary to using vibratory tools. This is a model of human body standing on a vibrating platform. So you can see the different vibrations in different parts of the body. This model suggests that frequencies between 16 to 30 hertz may be harmful for the lower arm, while the frequencies of 50 to 200 hertz may be harmful for the hand grip. So people who are using the vibration and regular vibration tools or vibratory tools regularly may be at risk of different type of musculoskeletal disorders such as hand-arm vibration syndrome, carpal tunnel syndrome, or arthritis. The problem can be vascular, neurologic, or different other type of musculoskeletal damage to the hand or fingers. The person may have numbness, tingling in the fingers, decrease of the sensation, decrease of the strength in the hands, may have episodes of pale and white fingers, especially when they are exposed to the cold environment. What is the cause? The cause is mostly vasospasm, spasm of the vessels, of the small arteries and veins in the hands. And sometimes it's a complete closure of the arteries because of the changes in the microvasculature, such as the hypertrophy of the arterial wall or the fibrosis of the blood vessels. I tried to introduce you different type of injuries in the upper extremity. Thank you very much for your attention, and in the next few classes we will learn different methods that we can recognize the people who are at risk of upper limb injury, and the methods that we can somehow prevent the injury in that part of the body. Thank you.